session, what we are going to do is, first of all, we're going to give you the overview of what is our regular course, how you can join that, and after joining, what is the material that you will be getting after joining the course. And then we're going to discuss about a very important topic for AMC preparation, that is nephrology, which Dr. Rajat is going to cover. So let's start with the overview of the courses of AMC that MedExam Expert is offering you. So in our regular course, what we are going to do is we will be having like 27 live sessions. In those 25 live sessions, we're going to cover every topic that is important for your AMC preparation. And we're going to cover theory regarding guidelines, about question discussion. We're going to cover every topic in this aspect in these live sessions. So there will be 4 mentors, 4 amazing mentors that are going to be with you in this amazing journey of your AMC preparation. We have Dr. Rajat, we have Dr. Nabira, we have Dr. Sumaya and Dr. Farhad. All are familiar doctors, you all know about them. So these 4 amazing mentors will be there for your guidance in your AMC journey. And apart from the live session, we are going to provide you the recording and the PDF of every live session. So in case any student out there is unable to join the live session, so on the very next day, we're going to provide you with the recording along with the PDF slides. Then we are going to provide you the AMC QBank, that includes 5,000 plus questions with correct answers and explanation. All the QBank will be available to you on the website, and this QBank is made through past papers, all the important questions, all the important scenarios, everything is added in this QBank so that you can practice as much questions you want, okay? And apart from the question bank, we're going to provide you quizzes and mini mocks just to boost up your preparation and help you to assess how well you are prepared for any topic. Then by the end of the course, we're going to provide you 3 mock exams that will contain 150 questions each, and it will be just like a real AMC exam so that you can practice more papers, work on your time management, and when you will be appearing for your AMC exam, you will be well prepared. And then apart from the mock exam and quizzes, we're going to provide you all the notes, all the flashcards, and all of the solve recall files. So you don't need anything else from this course for your AMC preparation. And our notes and flashcards are going to help you. So you don't need any other book as well. So everything will be covered in this regular course. So it is the best course for all the students out there who are starting their preparation right now and still confused that how to start the preparation, which topics I have to prepare. So we are going to guide you about all those important topics and how you can prepare them, okay? And this course is basically for 3.5 months, and it will be a long course so that all the topics that are important for AMC will all be prepared. So now let's look at the schedule. So how we're going to, cover all these topics. So what we're going to do is we are going to start module wise. We are going to start with medicine. Then once medicine will be completed, we will be having mini quizzes, we will be having medicine recall discussion, everything will be provided to you regarding medicine. So once your medicine module will be over, then we're going to start with psychiatry. Then similarly, we're going to cover surgery. Similarly, we're going to cover every important topic that is important for your AMC preparation. We're going to cover every module like gynecology, pediatrics, ethics, obs, and every topic that is important for your preparation. Every topic will be covered in the live session. And all the 4 mentors will be there to guide you and to conduct these live sessions. So these are some of the amazing reviews from all the students who have joined us and they have passed their exams. You all know about them. So these are some amazing results from our March, May, and April batches. So if any student out there don't want to go for the long course and he or she just want to practice questions that we have, or crash course as well. So some people were requesting that do let us know about your crash courses. So that's why I'm sharing this information with all of you so that you can make your decision wisely. So in the crash course, there will be 10 live sessions, and those live sessions will be apart from like only for the question discussion. No theory will be covered in these live sessions. We're going to focus on only the question discussion. And again, we're going to provide you with the recording, question bank, quizzes, everything will be provided to you. And the duration will be for 2 months. So if anybody of you wants to join the crash course, they can, join it. Now, for all the students, I guess somebody wants to talk. Yeah, so basically all the students out there who haven't joined the course, because we have a lot of students today who were curious about our courses and wants to join the courses. So this is bundle offer for all of you. If you want to join 2 courses in a bundle, you will get discount. Like you can get discount on regular course plus exam week sessions, and you can get discount on recall crash course plus exam week session. So if you want to avail the discounts, you can, just message us. Our team is going to guide you about how you can start your preparation and how you can get the discount and how you can join the course. So that was all from my side. Dr. Rajat, I guess you can share your screen now, and let's start discussing about nephrology.
Okay, so hello everyone. I'm Dr. Rajat. Today we'll be discussing about nephrology, and let me quickly share my screen with you all.
So Dr. is sharing his screen. So let us know if you have any question. You can write in the chat box. I will be there for your guidance. Okay, so let me quickly tell you about the regular course. When you're going to join the course, how you're going to access the course. So once the access will be given to you, you have to click on user dashboard, and then you will find courses. In the courses, you will find the course of AMC Regular Course. For all the students who have joined the course, this is for those people, but all the students who want to join the course, they have to first join the course, and then they can see this access on their screen. So basically, we have few options over here. The first option is the course content. In the course content, what we are giving is, we are giving you the short recall files in the PDF form. From 2023 till 2024, you will get all the files. So you can, read those files, know how AMC gives you questions. You can see the exam structure, how the questions are given, how they give you options, and how you have to select the correct option. And then we have some important recalls and the past recall papers. These past recall papers are basically. Hi, Dr. Yanten. Is my voice clear now? Can you please write in the chat box if my voice is clear? Okay, that's perfect. So yeah, I was telling you, in the past recall paper, you will get all the past papers in quiz form. You can see these names over here. These are basically the quizzes that you can attempt on the website. Okay, after attempting, you will get your score as well. You can see when you will click on the C answers, you will see the correct answers with explanation as well. So these are basically the quizzes that we have provided you as past papers. So in
What
course
time the
content,
course
basically
start?
you will find
What
all
time? What
files.
time the course start? What time the course start?
Dear, the course has started from today. Today was our first orientation session. That's why we are guiding you about what regular course is and what you will find after joining the course.
So I'm in Sydney, Australia. What time will be in Sydney, the course?
Yeah. So they are basically we will be conducting live sessions. Like there will be 27 live sessions in the course, and the live session time will be nearly 11 a.m. GMT. That will be nearly 9 p.m. or 10 p.m. in Australia.
9 a.m. Okay, I want
Yeah,
to join.
9
I
p.m.
want to
here.
join. I want to join, but I don't know how to join.
Sure, dear. You can just, I will drop my number over here. So after this webinar, you can contact me. I will give you all the details and then you can join the course.
Okay.
Okay, dear. So yeah, I was telling you about the course content. In the course content, you will find all the recall files. When you will click on the notes, you will find all the flashcards. Like for every topic, we have separate flashcard. Like for ethics, for ENT, for emergency, we have every flashcard out there that you can read and start your reading material and prepare the topics. In the notes, you will find some important notes that you can use to prepare again your topics. Then we have test. In the test, you will find the question bank. You will find every topic test over here, like dermatology, ophthalmology, neurology. You will find every topic test over here. So once you prepare the topic, you can come over here and attempt the test and see how your topic is prepared. Okay, you can assess your knowledge from here. Then in the recordings, you will find some recorded sessions that we have given you just to start your preparation, but rest of the recordings will be appearing here. Like for example, if today is the live session, so tomorrow you will get the recording over here along with the PDF. When you click on downloadables, you will find all the reference book and the guidelines that you will be needing for your AMC preparation. We have uploaded every book over here. If you need anything else apart from this, we're going to upload over here. You will get all the important files and books to start your preparation. So this was all for the course. So now let's discuss about nephrology topic. I will request Dr. Rajat to please share your screen now.
Excuse me.
Yes, please.
I have a question.
Yes, please.
If we extend the exam, so your course is only conduct for three and a half months, but if we will participate exam on next February, so until that time period, can we access to your website?
Okay, so let me guide you about this thing. The course is for 3.5 months, but if you will say us that I'm going to appear in February exam and I want my course access till February, then we're going to extend your course access. So we give option of extension. So you can extend your course till February or March or whenever once you want to extend the course. So it is possible.
Okay, so extension. So we need to pay extra money or for that for extend.
So yeah, what I was guiding you is that if you will let us know that okay, I want to join the course, but I want my access till February, so we are not going to charge you anything for that. Your access will be till February, so there will be no extra charges from your side.
Okay, thank you very much.
Is it clear to you?
So how long is the course, please? How long? How long?
Yes, Dr. Hawaida, are you asking about how long the course is?
Yeah.
So the course is basically for 3.5 months.
But my exam will be less than 3 months.
Dr. Hawaida, could you please write in the chat box? I guess your voice is interrupting.
I said my exam will be before 3 months.
Okay, so we have the option of recall crash course. If you want to prepare yourself in 3 months only or 2 months, then you can go for the recall crash course. That is a short course that will help you to prepare yourself for the exams.
Okay.
Just drop me a message after the session. I will guide you. Okay.
Okay.
Asma?
Yes, Dr. Rajat.
I'm not able to share my screen with the candidates here. So what I'm gonna do is I'm gonna share the PDF with you, and you can maybe open it and
Yeah, surely.
let's see how
Just
it
send me the
works.
PDF. Yeah, just wait for 2 or 3
Yeah.
seconds. I'm going to, share your screen. Thank you.
Can everybody please mute their mics? We're gonna start the nephrology session. So before we start, I'll just tell you a bit about me. I'm Dr. Rajat Gupta. I have done my MBBS and MD medicine from India, and also cleared my NEET super specialty exam. Then I also cleared MRCP 1, AMC 1, and right now I'm working with Queensland Health as a registrar. Okay, so today we'll discuss nephrology, and before we go to nephrology, I'll tell you I also have an Instagram handle where you can learn about basic medical things. It goes with the name dr_Gupta_MD, and there I post videos where there are clinical signs, some important topics, and things like that. So just be in touch. If you have any questions, you want me to cover any topics, you can message me there as well. So Asma, are we ready with the PDF? Yep. So yep. I think this is not full. Yep. The next slide will be. Yep. Okay. So nephrology, let's start with urine analysis. Although we go for multiple tests for the kidney functioning, that those are I can't write on it, Tasma, right?
Yes, Dr. Rajat, you can just view it.
Okay. So sorry guys, some technical issues, but I'll try to make it as interesting as possible without even typing over it. So let's see. And let me try once if I can share whiteboard along with it. No, I can't do that. Then my main PDF will be gone. So let's go. Asma, can you please share it again?
Yes, sure. Let me share the screen again.
Yeah. So we can go for serum test in which we'll check serum creatinine and electrolytes, urea. But before that, we can also check the urine analysis. So when you are analyzing any urine sample, you total number, like normally the protein in the urine is less than 150 mg per deciliter. That is normal. If it is more than that, then it's problematic. Then we have to go for the diagnosis and causes of it. And out of this 150, 30 mg per deciliter is albumin. That is the normal quantity. And if the albumin quantity is 30 to 300, it's microalbuminuria. And if it is more than 300, is macroalbuminuria. Okay. And if you quantify the protein in the urine sample for like 24 hours, and if the quantity is more than 3.5 grams, some books also say 3 grams, so it varies, but we'll go with 3.5 according to Australian guidelines. It comes into a range of nephrotic range. And if it is less than that but not normal range, then it is nephritic range proteinuria. And earlier we used to go for like 24-hour urine protein. We'll collect the urine sample for like 24 hours and then check the quantity of protein in it. But we have another option these days we call spot urinary ACR. This is called albumin creatinine ratio. That gives the equal like estimate of like good estimate of 24-hour urine protein. So it's kind of a substitute. Okay, so after going for urine analysis and protein, we talked about proteins in urine. We go for the cast. We see different kinds of cast in urine. If we see like WBC cast, it is seen in pyelonephritis. So pyelonephritis is an infection, and wherever there is an infection, the WBCs go there to attack. So when they try to filter in like glomerulus, then they are these are basically dead WBCs. They are seen in pyelonephritis, and we can see WBC cast in interstitial nephritis as well. And to be more specific, it's like eosinophilic cast. If we see RBC cast, they are seen in glomerulonephritis. There can be multiple causes for glomerulonephritis. Could be allergy, autoimmune, different diseases. We'll discuss in like further lecture. And if we see broad vexicas, these are chronic renal failure. Just imagine if there is like chronic renal failure, kidneys are shutting down, then everything will be like all vexy. So you can memorize it like that. Broad and vexy casts are in chronic renal failure. But if there are muddy brown casts, then the disease we identify is acute tubular necrosis. When there is necrosis, the cast will be muddy and brown, just like the slough. Okay. And if we see the hyaline casts are normal. Okay. Now let's move to the next part. Whenever we test urine for microscopy, before that we go for urine dipstick, in which it is a simple test to identify whether there are proteins, whether there are RBCs or not. So if urine dipstick is positive for blood, then we go for microscopy, because urine dipstick can be falsely positive in myoglobin urea as well. So if there is any muscle destruction like rhabdomyolysis, any seizure, and excessive exercise, that can cause like positive urine dipstick. But on microscopy, there will be no RBCs. That means there is myoglobin that's causing urine dipstick to be positive. So after urine dipstick, we'll go for microscopy. And on microscopy, we see the RBCs. RBCs, the morphology of RBC is very important whenever you are assessing a patient, because if the morphology is normal, that means the RBCs are from the tract below kidneys. Okay. And if the RBCs are from like above kidney, they have to cross the glomerulus. And when they are crossing the glomerulus, they'll be distorted. There will be destruction. So no typical shape of RBC will be maintained if it's coming from the kidneys, because of the filtration. And that's why if there are dysmorphic RBCs in microscopy, the urine will be cola colored, source above kidney, that like example being glomerulonephritis. And if the RBC shape is intact, that means the RBCs haven't crossed the glomerulus, and they are directly coming from the ureter, bladder, urethra. Hello. Yeah. So the most of the causes are surgical causes if the RBC shape is intact, like any trauma, any surgical causes, stricture, polyp, cancer, growth, anything can be there in which the shape of the RBC will be intact. It's a very basic concept and important thing to remember. Let's move to the next slide. Asma, let's move to the next slide. So when we are talking about the RBCs, just remember if a patient is so if the patient is having painless, frank blood in urine, even if when you are practicing and you see a patient who complains that I am passing just blood in my urine, always think of bladder cancer. It's common. It's not like a rare entity. You will see like 2-3 patients in your during your residency maybe. And sorry. So if a patient who's having loss of weight, loss of appetite, and is passing just blood in the urine and it's painless, first thing to come in your mind should be bladder cancer. And the history in this patient would be he might have worked in like dye industry. It's common in that thing. Okay, so Asma, let's move to the next slide, please. Okay, so when we are talking about kidneys, there are nephrons, and the part of nephron, the like head part, is called glomerulus. Due to its problem or any disease, any injury, there are two kind of presentations. One could be nephrotic, and other could be nephritic. So as we told earlier, whenever there is like more than 3.5 grams in 24 hours, it's gonna be nephrotic range proteinuria. If it is less than 3.5, it's nephritic. In nephrotic syndrome, the hematuria is not so common, but it's very common in nephritic syndrome. Because whenever there is any allergy, infection, there is inflammation basically in nephritic syndrome. And but as you can see in nephrotic syndrome, the protein loss is so much that patient presents with anasaka, whole body will be swelled up, the legs will be totally, they might be dripping water from the legs. So edema is main presentation in nephrotic syndrome. However, nephritic syndrome patient will can also present with edema, but there will be hematuria as well, and patient will be having hypertension in nephritic syndrome most commonly. So whenever there is protein loss in nephrotic syndrome, the proteins that are bound to the cholesterol are also lost in the urine. That means that the free cholesterol is increased in the blood. So fatty, the urine will show fatty cast, and in serum, the cholesterol levels will be high. But this is not so common in glomerular disease. But you can see RBC cast as we discussed just like in the previous slide. Second, in nephrotic syndrome, along with the protein, like cholesterol binding proteins, there are immunoglobulins that are lost in with the urine. So immunity is down and increased risk of infections are there. Similarly, antithrombin 3, protein C, and protein S, these are the proteins that prevent blood to clot. So if they are lost as well, there are very high risk of thrombosis. The blood will clot in the like body. So like any stroke, any PVD, any DVT, you can see, sorry, not PVD, it's like DVT, stroke, MI, anything can happen due to thrombosis. So now we will come to the causes of the nephrotic and nephritic syndrome. most common in children is, sorry, back like previous slide, please. Yeah. So causes are minimal change disease. This is most common in children. The child will present with similarly edema and proteinuria. So if what happens in minimal change disease, the food process of the podocytes, like the glomerulus, there are food processes. Sorry, in the glomerulus there are podocytes. They like they are normally they are sticking with each other, and there are no gaps. But in minimal change disease, the food process are shortened and are absent. So there is a plenty of gap leading to increased passage of proteins in the urine, leading to minimal change disease. The causes could be any insect bite, any NSAIDs, any allergy, or maybe idiopathic in the children. We'll discuss it later as well. The other cause could be membranous, uh, uh, then can be focal segmental glomerulosclerosis. The other cause is diabetes mellitus. We see proteinuria in diabetes mellitus in advance. So it is also very common in adults. So it's most common in adults. The other cause is amyloidosis, in which there are protein deposition in the kidneys and different organs, leading to nephrotic range proteinuria. In nephritic, there are like post-streptococcal glomerulonephritis and IgA nephropathy. IgA nephropathy is very common, and we'll discuss in the further slides as well. And then there are some conditions like ANCA positive glomerulonephritis, Alport syndrome, membranoproliferative glomerulonephritis. These three can present as nephrotic as well as nephritic syndrome. So we have to just like evaluate the patient, like what kind of disease he's presenting with. So the result of this slide is, just keep in mind, if your question says that a patient or a child presents with generalized swelling of body, that means anasaka, and the urine shows 3 plus proteinuria, 4 plus proteinuria, blood pressure is normal, nothing else is there, the first thing should come to your mind is minimal change disease, because the patient is presenting with nephrotic syndrome features and he is a child. So minimal change disease is the most common. You should go with that. Or if there is a question saying a patient is coming with similar presentation like anasaka and recurrent infections as well, and he's a diabetic, you should consider like diabetes mellitus causing nephrotic syndrome. Okay, so let's move to the next slide, please. Okay, so as we discussed earlier, minimal change disease, its the causes could be idiopathic, NSAIDs, insect bite. Another cause could be Hodgkin's lymphoma, and in these diseases there are plenty of causes, but we are talking about the important ones here. So these are the causes that can lead to minimal change disease in children. So the young child, anasaka, proteinuria, BP, and RFT, blood pressure and renal function tests are normal. You should think about minimal change disease. So how you will diagnose the patient? The diagnosis is a renal biopsy, and then you go for electron microscopy. Usually we go for like a simple microscopy, then immunofluorescence. But as there is nothing to be like any immune deposit or something like that, it's just that the food process of the podocytes are not there, and they are like absent. So there will be no deposits. So under the normal microscope, there will be nothing seen on the biopsy. But if you go for the electron microscopy that sees the minute things, then you'll see that there are no podocytes, no food process in the podocytes. So that's how you'll diagnose minimal change disease. Now let's come to the treatment. Treatment is steroid and cyclophosphamide. And let me tell you that the response with the steroid is very good in this patient. You put the patient on steroid like high dose, 1 mg per kg. You don't have to remember the dose, but I'm just telling you that you start with the high dose steroids. After 2 weeks, you start tapering, and you will see how patient is improving. And if you want to improve the symptomatic improvement, you want to give patient some improvement in symptoms, you can also give some diuretics like Lasix, we call furosemide, and loop diuretics work very well with these patients. The second disease is membranous. In membranous, you should remember hepatitis B and cancers like lung cancer, colon cancer, and other causes could be idiopathic hepatitis B, malaria, syphilis, or any NSAIDs. These can cause the membranous changes in the and present with the nephrotic syndrome. So, an adult with NSHACA and proteinuria, similar presentation. But in this, there are like immune deposits causing thickened basement membrane. So, if I tell you, I'm trying to share a whiteboard for everyone. So Asma, you'll have to share your screen like in 2-3 minutes. I'll tell you. Okay.
Okay, sure.
So this is the glomerulus. There are different type of podocytes. Like these podocytes are like right next to each other. These are podocytes. This thing is called foot process. The foot process are connected with each other, so there is no gap, so that protein can't pass this membrane. But in minimal chain disease, these podocytes are like this. So there is plenty of gap, and the so the protein can pass. Okay, and this membrane, like I'm not sure why it's getting cleaned. Okay, so this is the glomerulus. There are podocytes. Like I'm just drawing them roughly, and the layer where podocyte rest is called basement membrane. So in this layer, there are like immune complex deposition leading to. Asma, can you share? Yeah. So you should remember that the basement membrane will be thickened, and there will be subepithelial deposits in this. You just have to remember this, because if we go into too much detail of these deposits, you will remember the process, but you'll forget like what kind of deposits were there. That subepithelial, subendothelial. So don't confuse, just remember, in membranous, basement membrane is thickened. So membranous with membrane, and there are the epithelial membrane. So below that there will be deposits. So if there are deposits underneath a membrane, then there is the presentation seen on the microscope is called spike in dome. And the immunofluorescence we can see like spike in dome appearance. It is important. So in the pattern, you will see like there are deposits under the epithelial layer. Then the pattern you see is also known as granular pattern, like just like small granules. And in clinical practice, what we see is if we can't go for renal biopsy, and there is nothing you can do, because most of the countries we are working are like resource limited countries, and we can't go for biopsy for all the patients. We can also send like phospholipid. We can also go for MPLA2 test for serum. In serum, this can be positive. It is, the full form is membranous phospholipase A2. This will be positive in blood in membranous glomerulonephritis. So keep in mind, if a patient with a history of lung cancer, in a question, the patient is there with a history of lung cancer, he's undergoing treatment or he has just completed it, and he presents with the proteinuria, then you should always remember that it could be due to membranous. Okay. Membranous disease in cancers, lung cancer, typical example I'm telling you guys. The next is focal segmental glomerulosclerosis or nephritis, you can say both. So as the name suggests, focal segmental, there are small focus in the kidney where there are the damage to the nephrons and stuff. So the most important example is HIV. In HIV, you will see focal segmental glomerulosclerosis or nephritis. So focal sclerosis will be there, can be seen in HIV. The AMC is very fond of sickle cell disease. So they can also frame a question with the history of sickle cell disease, having the complaints of Hanasaka, proteinuria. So you have to look for the catch given in the question. Like, what's the catch? Is the patient having hepatitis C or hepatitis B? What should be in our mind? How is the patient's presentation? It is nephrotic or nephritic? Okay, is the patient hepatitis B, C positive, or is there any issue of lung cancer or HIV? So you keep these things in mind. Also, FSGN can be seen in heroin abuse and reflux. Reflux is when there is any obstruction below the, like in below kidneys, like in ureter, urethra, bladder, anywhere, and the urine is going back, and due to the back pressure, there are some areas that get damaged, causing FSGN. Okay, please next slide. Okay, so next is diabetes mellitus. It also causes proteinuria leading to nephrotic syndromes. See, the disease not always presents like nephrotic range proteinuria, but it starts with proteinuria. Whenever there is proteinuria, the filtration will be higher initially. Then with higher filtration, that means EGFR, the glomerular filtration rate, we normally calculate like more than 90 is normal, and then it comes down stage 1, 2, 3. There is a classification for that. You can easily get it anywhere, like CKD classification you can search. So whenever there is initial damage to the kidneys, you always check urine in diabetic patients. You can go for urinary ACR to check for microalbuminuria. So initially there will be microalbuminuria with the hyperfiltration, then macroalbuminuria. After that, the GFR will start declining. And I'm not very sure about it's not very important to remember the terms, but there is Kimmelstein granules in the diabetes mellitus that can be seen and in the microscopy in the diabetes mellitus. So this is about the diabetes. Then the next condition we are going to discuss is amyloidosis. See, what is amyloidosis? Amyloidosis is the excess deposition of proteins in various parts of the body. Like it can be spleen, kidneys, liver, like any organ, in fat pad, so skin. So there are different organs that can be involved in the amyloidosis, leading to proteinuria and nephrotic range proteinuria. So how to diagnose it? Before we go to the diagnosis, the patient will be having any underlying condition like rheumatoid arthritis, IBD, inflammatory bowel disease. Like there is persistent inflammation in the patient, and there is inflammation, there are antibodies, and there are higher protein formation. These proteins get deposited in different organs, leading to larger size kidneys and renal damage as well. See, when there is protein deposition around the kidney and there is always some compression, leading to compression, the damage will be more, and ultimately there is renal failure. So this is so to diagnose amyloidosis, what we can do is we simply get a fat pad biopsy, or you can go for visceral biopsy like the renal biopsy or biopsy from any other organ. And after getting that biopsy, we stain it with Congo red stain and see under polarized light, and it looks like apple green by French. Okay, so you just have to remember the name of the stain, the light, and the color. Apple green by French. Okay, next. So in the photo, you can see like there were proteins and the bigger size kidneys. And as we just discussed about the kidney size, can you tell me what all are the conditions, like usually when there is chronic kidney disease? When we call it a chronic kidney disease, when there is decreased GFR is decreased, and it is like creatinine is increased, leading to decreased GFR, and uh, the size of the kidney is shrunken. But this derangement should be for more than 3 months. You can't label anybody with creatinine 2 or 3 in a single setting saying it's CKD. No, because it can be temporary. So if the patient is having deranged RFTs for like more than 3 months, then we call CKD. And whenever there is CKD, the size of the kidney shrinks. See, when we are not using any organ, it obviously goes gonna shrink down, like this is a trophy kind of thing, just to memorize it. So there are some conditions in which the size of kidney is not decreased, but is increased. So amyloidosis is one of them. Other condition can be HIV. Third could be autosomal dominant polycystic kidney disease, we call ADPKD. Okay, so these are the different causes. There are multiple causes as other causes as well, but I've just told you the most important ones. Now we are finished with the nephrotic range uh, proteinuria diseases. There are now nephritic range proteinuria conditions. So there is an important difference between PSGN and IgA nephropathy. PSGN is post-streptococcal glomerulonephritis, as the name suggests, post-streptococcal. So, whenever there is streptococcal infection, that means throat infection or any skin infection, then there after like few weeks or few months, there is hematuria, hypertension, RBCs in urine, then you think about PSGN. It is also known as diffuse proliferative glomerulonephritis. So, if a patient is having history of sore throat, and the patient can present with hematuria after 2 weeks, and if there is history of like in question there is history of skin lesions, then likely he'll present after 1 to 3 months. Like the question will be, the patient is presenting with proteinuria 1 plus and blood in urine, and he had a history of skin, skin infection 1 month back or 2 months back, and now you diagnose. So there are some options. So you can rule out the options with nephrotic range proteinuria conditions. From the nephritic range, there will be these differentials like PSGN and IgA nephropathy. How IgA nephropathy is different? In IgA nephropathy, the hematuria will present when the patient is actually having the sore throat or pharyngitis. So it is called synpharyngitic nephropathy. So if a patient has a history of sore throat, then most likely it is PSGN. If he's right now having sore throat and presenting with nephritic syndrome, then IgA nephropathy. And I'll tell you, IgA nephropathy is not so uncommon. It is seen, it is commonly seen sometimes. And the prognosis of IgA nephropathy is not good, because see, the kidney involvement is simultaneously with the throat infection. See how severe it can be. So just remember, can you please mute your mic, whosoever is there?
Yeah, kuziga henchi mena iga research. Anjemi that attend.
Asma, can you please mute the candidates?
Income everything.
Okay, so the infection is so severe that even with the 2 days of sore throat, his patient is presenting with nephropathy. So you can learn it by this mnemonic kind of thing. The prognosis will be bad, and as the name suggests, IgA levels will be high. Okay, and the IgA is a protein, and antibody, and it's a protein. So just remember, like protein nephropathy will be fluffy appearance on the microscope. So bad prognosis, increased IgA level, and fluffy appearance in the microscopy. And in PSGN is post-streptococcal, so it came later. It's good prognosis. IgA level will be normal. Complement levels I haven't mentioned here because it will confuse you guys. The complement levels initially can be down, then it's normal. And the microscopic appearance is starry sky appearance. Okay, just you have to remember this point, starry sky appearance in PSGN. Now next comes ANCA positive glomerulonephritis. These are the enzymes we check for in the autoimmune diseases. ANCA positive glomerulonephritis, there are few examples: microscopic polyangiitis, Churg-Strauss, and Goodpasture syndrome, Wagner's. So there are two type of ANCA tests, like P ANCA and C ANCA, and in all the diseases will have P ANCA except Wagner's. Wagner's is C ANCA. Okay, so these are some kind of vasculitic syndromes. Vasculitic, in simple words, there are like autoimmunity. There is autoimmunity that affects vessels of medium-sized vessels. So in all these four diseases, the vessels in lung and vessels in kidney are involved. That's why these are called pulmonary renal syndromes. So if a patient, in the question, if a patient is presenting with hemopsis and there is hematuria and proteinuria in urine, you should think about pulmonary renal syndromes like ANCA positive glomerulonephritis. Then somewhere in question there will be a slight clue that the patient is having C ANCA positive. Then you think of Wagner's glomerulonephritis. Or if there is any clue about, like, okay, there were linear deposits because they are linear, they are good, seen in Goodpasture syndrome. So these are the tricks to remember the things that you have to cram. So linear deposits in Goodpasture syndrome. Okay, yeah, let's go to the next page. Okay, then we go to membranoproliferative glomerulonephritis. It's also a different kind of glomerulonephritis we just talked about. It is seen in hepatitis C and cryoglobulinemia and etc. There are different diseases, but all the glomerulonephritis, there could be cause like idiopathic, where we don't know what caused the MPGN. So MPGN is of two types. MPGN1 and MPGN2. The point to remember is MPGN1, you will see tram track appearance due to subendothelial deposits. And MPGN2, there will be dense deposits like ribbon-like. Okay, so as I'm talking about subendothelial deposits here, can you recall where we saw subepithelial deposits? Comment, guys. Can you guys tell me where you saw subepithelial deposits? Yes, good. So in membranous, we saw subepithelial, but here there are subendothelial deposits. Good. And spike in dome appearance was in membranous. There are synonyms. But here, don't confuse. MPGN1, first is tram track, they're also called subendothelial, and the second is dense. Dense is ribbons. Dense, like filled with ribbons, maybe. You remember, you just make your own mnemonics. Everybody has their own way of learning things, or basically, I'll say cramming things. If you have to cram something, cram properly. Make a good mnemonic, and you'll be good. You don't have to stress, you don't have to stress about not recalling during the exam, because in exam you are so stressed, the mnemonics help. Okay, now next is Alport syndrome. What is Alport syndrome? So basically, I'll tell you, type 4 collagen is not like it's defective, or it's not being produced in the body. So Alport, type 4 collagen defect. So type 4 collagen is present in lens, in cochlea, and glomerulus. So this is a mnemonic to remember. So in lens, it can cause lenticonus myopia. In ears, it can cause sensory neural hearing loss. And in kidneys, as there is no collagen 4, so there will be gaps in the kidneys. Simply just to remember. So the basement membrane, there will be gaps in the basement membrane because there is no type 4 collagen. So it will look like basket with the gaps. So basket V appearance. And renal problems due to the hematuria and everything will be there. Treatment is transplantation, exact, because if there is no protein, if you transplant the kidney, there is no problem with that. Your new kidneys will work properly because there are no immune deposits. It's just that the body is not making type 4 collagen. And if you go with the A in the starting, they're like treatment for the hypertension, you should go for ACE inhibitors or ARBs. A looks like 4, so type 4 collagen defect, as I told you. Hereditary and X-linked. So this word should be in your mind whenever there is a question of Alport syndrome. So nothing else about Alport we need to remember. This is enough information for your exam. Yeah. So next topic is polycystic kidney disease. It could be autosomal recessive, autosomal dominant. But if a patient is having autosomal recessive kind of kidney disease, and it is present in a patient, then it dies in like uterus maybe. So we see only autosomal dominant type polycystic kidney disease. So the patient will be having large kidneys, as I told you earlier. Recurrent UTIs, because there is cyst, there is water and the fluid that is more prone for infection. Whenever there is infection, recurrent pyelonephritis, UTI will be there. If a cyst ruptures, it can cause hematuria, but there is no glomerulonephritis, no infection at that time if it's rupturing. So it will be painless hematuria. Recurrent UTI, hypertension will be there due to repeated injury or the cyst compressing the kidneys. CKD can develop, leading to hypertension, creatinine will increase, and the family history will be positive in these patients. So how to diagnose it? We screen the patient. If there is a person with ADPKD, we have to screen the children in like every few months or a few years, depending upon the status and number of the cysts. So we keep on checking. The check will be done with the ultrasound. You just have to keep on checking the kidneys with the ultrasound. If there is any cysts, like more than 5 cysts, there is high chances developing ADPKD. So for ADPKD, there are two genes. The gene 1 is on 16 and 2 is on 4. So you just make your mnemonic if you can't remember, but I think 16 and 4 is simple to remember. Okay. And the next topic is renal artery stenosis. There is a lot of confusion and controversy whenever you are talking about this treatment. I'll simply tell you today how is the treatment. So what is renal artery stenosis? That means there are two kidneys and one kidney or two kidney. The blood supply is hampered due to stenosis of the renal artery. If it is it's only one kidney that's compromised, then kidney will produce renin that will convert angiotensinogen to angiotensin 1 and then angiotensin 2, leading to increased BP. And this increased BP will damage the other kidney as well due to hypertension leading to trauma. So we have to control the hypertension, and we should give patient ACE inhibitor or ARBs. They will inhibit renin and ACE and renin to stop the production of angiotensin 2 that will cause increased BP. So to check the BP, we will give ACE inhibitors or ARB. But if there is bilateral renal artery stenosis, and if you give ACE inhibitors or ARB, then the BP will be lowered down due to the drugs you just entered. But as the BP will be lowered down, the supply to both the kidneys will be totally shut down because there is already stenosis on both the kidneys. So there will be no blood supply. When there was only one kidney blocked, the other kidney was damaged due to hypertension. So to control that, we were controlling hypertension. But in bilateral, you can't control it to much better, like to an extent, because the kidneys will be devoid of blood, devoid of oxygen, leading to CKD. So you don't give ACE inhibitor ARB in bilateral renal artery stenosis. So on ultrasound Doppler, you can check the flow and if there is any stenosis or hampered flow. So after that, you can, if you want so first choice of investigation is USG Doppler. That first test you ask the patient for diagnosis. So that's the first choice. First test, and then there comes the golden test, like best test. The question will say best test, then you go for MR angiography. MRI of vessels, MR angiography. So that's the best test. But best test is never the first test in most of the cases. So don't get confused. Yeah. Let's go to the next page. So if a question, patient is started on telmisartan and the creatinine is doubled. In normal patient as well, we expect creatinine to increase up to like 20% of the normal value. That is acceptable. But if it is doubled or it's severely increased after adding telmisartan or ramipril or drugs like these, then you should think about bilateral renal artery stenosis. Okay. And as we discussed about amyloidosis in our previous slide, underlying inflammatory disease is there, like rheumatoid arthritis, IBD, chronic infections are there. And due to this, the higher protein content leading to deposition around the kidneys and different organs. The patient will have macroglossia, hepatosplenomegaly due to everything will be big, The tongue will be big, spleen and liver, and the patient will be having loss of appetite, loss of weight. Okay. Yeah. So can you quickly tell me what was the color of the biopsy? We see under polarized light, and Congo red stain is done, and we see in the amyloidosis. Can you please quickly comment what was the color of the bifringe?
Apple green.
Yep, good. You guys remember things I just told you. It's good, like you are listening. I'm happy with that. So the renal part is almost the notes. There is a bit of surgical part. I'm just gonna tell you clinical things that will help you in your future training as well, along with the exam. So there could be swelling in the testicular area if the swelling is painless and cystic swelling, and it is present in the posterior upper testes, is most likely epididymal cyst. So you can go for light test. You just you know how to check the cystic lesions. We pass the light from one side and see if it's coming out from the other side. So if there is cyst, it will be clear cyst. You will see the light crossing it. So the position, cystic, painless, this will give you a clue to the diagnosis of epididymal cyst. You can also remember like epi on the upper part, okay, and didymal cyst, cystic lesion. And if you see the bluish compressible swelling, that's probably due to dilated veins, testicular veins. We can see, like I have shown an example, like some people have in the leg as well. So something like this you can see, and it's like bag of worms kind of feeling, like vessels are dilated. So this can be the diagnosis. How that's how you can make the diagnosis of varicose vein. Next, now comes HUS. It's very deadly disease, hemolytic uremic syndrome. So there is a triad in this. If a patient is having any recent infection, most commonly is E. coli diarrhea. E. coli, there will be diarrhea and abdominal pain, and the patient will present to you in like sepsis. The patient is toxic looking. HB will be less because due to hemolysis, microangiopathic hemolytic anemia. So hemolysis will be there, platelet will be down, and renal shutdown will be there. So this is the triad in HUS. And if there is a similar disease with the HUS, we call, we'll read further. I just forgot the name. We can discuss in the upcoming slides. So in HUS, remember three things: blood low due to hemolysis, platelet low, and renal shutdown. Okay. Yeah. And the second disease similar to presentation with HUS is TTP, thrombocytopenic purpura. In TTP, along with these three, there will be fever and altered sensorium. So along with renal and blood, there will be fever and brain involvement leading to altered sensorium. So if a patient is coming with the renal shutdown and hemolytic anemia, and their platelets are also low, but you'll see there is a history of like patient is a febrile, you don't go for it, HUS. Although I just told you like it is due to E. coli associated diarrhea, but patient will never be febrile in HUS, but in TTP, patient will be febrile. Maybe the GCS is also low. So TTP and HUS, key point to remember. Okay. Next is rhabdomyolysis. In rhabdomyolysis, it is basically destruction of the muscles, leading to myoglobin in the kidneys. Myoglobin is a toxin for the kidneys. Basically, it shuts them down. So as I told you, dipstick will pick blood, but microscopy no RBCs, because that was myoglobin. Myoglobin leading to renal injury, acute kidney injury. And the causes of rhabdomyolysis could be trauma, burns, increased exercise, excessive exercise, and cancers. Chemotherapy, when you start chemotherapy in cancers, there can be muscle lysis or cell destruction leading to this presentation. So can you tell me, like, what is the treatment? Treatment for rhabdomyolysis is giving plenty of fluids, IV fluid. Just wash the kidneys. Don't let the myoglobin, hydration. So you just flush the kidneys with the fluid as much as possible, as much as patient tolerate. You just load the patient with fluid and it filters the kidneys. So let's move to the next topic. So now, see, bicarbonate, I don't think there is a role of bicarbonate, but if there is any study, I'll have to check. As far as I know, the fluid is the only treatment that's needed. Okay, so the main conceptual part is over now, and we'll start the boring part. I'll try to make it interesting as well. Stay with me. So, as I told you, TTP, combination of renal failure, thrombocytopenia, pyrexia, or there is a pentad. And not here, we have written only 3, but there is a pentad. I just told you, so put it in your notes, save it somewhere. Pentad in TTP, P, pentad. So, TTP, P, say pentad. Okay, and HUS usually seen in younger with acute renal failure, thrombocytopenia, hemolytic anemia, just discussed. IgA nephropathy, all we studied about IgA nephropathy. Can you tell me, in a patient of pharyngitis, how many after how many days IgA nephropathy will present if a patient is having pharyngitis now? Yeah, 2 weeks is wrong. 1 to 2 days. It's synpharyngitic glomerulonephritis, IgA nephropathy. IgA, it's a good prognosis. Sorry, it's a bad prognosis because it's so quick. Okay, so don't confuse with the PSGN. It's IgA. So it is also called Buerger's disease or mesengoproliferative glomerulonephritis. Okay, yeah. So next is peritoneal dialysis. It's a kind of a dialysis renal replacement therapy in which there is there is a hole in your peritoneal cavity and abdominal cavity. You just put some fluid, let it rest for some time, like few hours, then you take it out. So whenever you are doing some invasive procedure for the abdomen, the bacteria on the skin are most common to infect it. So in PD, peritoneal dialysis, Staph epidermidis and Staph aureus are the main causes that cause infection in peritoneal dialysis. And second is next is primary hyperaldosteronism. So it is hyperaldosteronism. So there is more aldosterone. Primary means from the organ. Primary means from the primary organ that produce this hormone. So due to aldosterone adenoma producing aldosterone, it is known as Cohn syndrome. So in Cohn syndrome, hyperaldosteronism is there, and the function of this hormone is, whenever there is urine in urine, the sodium is filtered, and when it reaches DCT, the sodium is absorbed back, and potassium and H plus is thrown in urine in replacement. So this will cause, in the function of aldosterone is to increase the sodium intake from the kidneys. So it flushes potassium and H plus ions. So patient will be having hypokalemia, potassium will be less, and alkalosis because H is also going in urine. So urine will be acidic and patient will be having alkalosis. So on ABG, pH will be alkaline in patient. Okay. So next is allopurinol reduces formation of uric acid stones because it prevents the formation of uric acid from hypoxanthine by inhibiting xanthine oxidase inhibitors. It's a uric acid treatment drug. So simple. And pyridoxine and cholestyramine reduces the oxalate stone formation because in pyridoxine deficiency, the oxalate absorption is more from gut, and in cholestyramine, it just make a compound with the oxalate that won't allow it to absorb. So just simply learn these things. Calcium stone formation occur due to hypercalciuria and can be reduced by thiazide diuretic because thiazide diuretic decrease the urine excretion of the calcium. Cystinuria is a risk factor for renal stone formation. Obviously, cystine stones are also there. Okay. Yeah. And I think I forgot to share. Yeah. I'll also share one photo I have just shared with Asma after completing this module. I'll share that photo and teach you guys about something about stones, the basic things. Okay. Nephritic syndrome commonly presents with hematuria and hypertension, as I told you. When prescribing fluids, the potassium requirement per day is 1 millimole per kg per day. Not so important, but just if you want to, make a tick that you know almost everything. Okay, now in the next slide, we'll see how the renal stone look on the X-ray. Can you adjust the screen? I can't. I can't see number 13. Wait, it's okay. So the cystine stone are like, it's okay. The 13th point is cystine stones are semi-opaque. Opaque is white. Can you click on the little cross? Yeah. So cystine stones are semi-opaque. So semi-opaque. Opaque means white on X-ray. And the urate and xanthine stones are radiolucent. Radiolucent, that means black. So you just have to cram this part most likely because there is not a concept, except if there is calcium oxalate stones, they can be look white because there is calcium, but urate stone will look black on
Excuse me, doctor. We can move the screen. We can move the screen. The
you
screen.
can't move this.
No, because I'm in
Asma,
number 7.
Okay, you are still at number 7.
Yeah.
Okay.
But I can. I can. Yeah. 7 pyridoxine and cholestyramine.
Yeah.
Reduce the oxalate stone formation.
Yeah. Can you see the number 8, 9, 10 now?
Yeah, but we haven't go through number 7, pyridoxine and cholestyramine reduce the oxalate stone formation.
Yeah, because cholestyramine makes a compound with oxalate that doesn't allow the absorption of oxalate. When there is more oxalate in blood, then it make the calcium oxalate stones in the kidney. They're like most common stones in kidney. So that's how it works. You just have to remember a few things. Okay, let's move to the next page. Yeah. So MPGN types, there are 2 types I told you. Type 1 Cryoglobulinemia, hepatitis C, type 2 due to partial lipodystrophy. Now you just tell me what kind of what you will see under microscope in type 1 MPGN, and what you will see in type 2 as well. I just taught you. I know it's very hard to remember things because all these names are so confusing, but once, yeah, good, you guys are good. Yeah, in type 2 there will be ribbons, dense ribbon. Good, very good. So yeah, the class is helping, I guess. Okay, so the causes I taught you earlier, you just have to remember a few things, few concepts. The number 18, alpha calcidiol is used as white. So see, there are different compositions of vitamin D. Calcitriol and alpha calcidol are like active form of vitamin D, because if you give inactive form that we take, in the sachet we take weekly, you must have seen, they are like inactive form of vitamin D. If we take it, they go to our kidney and transferred into active form and help our bone grow stronger. But if you give those sachet to a CKD patient, they won't get any improvement because the kidneys are not functioning. So we have to give them active form of vitamin D, that is alpha calcidol, or we can also say calcitriol. And the time taken from AV fistula, almost 2 months. For dialysis, AV fistula is important. It takes 2 months. Well, next point we have done. Okay, 21. Telveptan is vasopressin receptor 2 antagonist. We give it in SIADH. So this is just a point to cram. SIADH treatment, tolvaptan. So we'll talk about something about stones. Asma, I have sent you a photo. Can you please show that?
Yes, sure.
So in this time till Asma is showing us that picture, you just relax because that's too much information for you guys today. Even I can get some voice break. Yeah. Can everybody see it? So there are 4 types of stones in kidney. The most common is calcium oxalate. So calcium, when you guys take calcium like empty stomach and there is oxalate and they get absorbed, and due to the excess intake of calcium, the calcium and oxalate combine in blood or in urine to form the calcium oxalate stone. As the name suggests, calcium oxalate, OX, and OX looks like envelope, and I can't write on it. So sorry guys, I can just talk about it. There's a mnemonic like calcium oxalate. OX looks like an envelope, so the stones under microscope will look like an envelope. Struvite stones, these are due to the infection, these are 10%, and these stones are due to the alkaline urine, due to the Proteus mirabilis. It causes ammonia. It will process the ammonia and make the environment alkaline, leading to staghorn struvite stones. And the next is uric acid stones. Can you remember what kind of, like, how the uric acid stone will be seen on X-ray? Will it be like they be white or black, if you remember? They will be, yeah, black. Very good. So because the uric acid stones are radiolucent, they don't shine on the X-rays, and the cystine is opaque. Bilkul, right? Okay, so let's go back to the yeah. Okay, so we discussed about Proteus mirabilis infection, struvite kidney stone, Staghorn calculi. These all are the same thing. Okay, alkaline urine. So these stones are very big and they obstruct the kidney directly. And you have to operate these patients to get the stones out because these stones are very big. And next is, whenever there is a young patient with asymmetrical kidneys, like one kidney is small and other is normal size or bigger, then you have to think about fibromuscular dysplasia leading to decreased blood supply to the kidney. Okay, and in any patient, just make it a habit. Any patient with chronic disease, it's not the disease that killed the patient, it's always the cardiac issue, ischemic heart disease in CKD. Because if the patient is having defected kidneys, it's a chronic kidney disease. The patient will be chronic with the same problem, but due to the complications, the heart can't, take the burden of all the diseases. So mostly all the patient, almost, I'm not saying all, almost all the patients die because of ischemic heart disease or cardiovascular event. Calciphylaxis is a condition in which there is an ulcer on the foot due to excessive calcium in CKD patient. You keep on pumping calcium to the patient. Okay, take this tablet 3 times, 4 times, and you don't check the calcium in the patient. And due to that, the patient will have this calciphylaxis, and there will be ulcerated area, most likely on the leg with necrotic center. Contrast-induced nephropathy, whenever you send a patient. Hello. So whenever a patient goes for CT, any kind of contrast enhanced CT, the contrast can damage the kidneys, and the damage appears at like after 2 to 3 days, and like in up to 5 days you will see the kidneys being like, creatinine is increasing because you send the patient for CT scan and you didn't notice that they gave the contrast. So to avoid that thing, you just load the patient with some fluid before the CT and after the CT as well, if the patient is not cardiac or not very old age. So yeah, that's like nephrotic syndrome is a hypercoagular state. I told you earlier. ADPKD we discussed. CMV is the most common and important viral infection in solid organ transplant recipients. It's very common question to be asked in all the exams. CMV, just remember, this virus infects the transplanted patients. Coagulase negative staph is the most common cause of peritonitis secondary to peritoneal dialysis. We discussed earlier. The epidermidis is also there to infect. Other causes of HUS, first we discussed was E. coli, and there could be other causes: Streptococcus pneumoniae, Shigella, HIV, Coxsackie virus. Yeah, next. The most common classical presentation is E. coli 0157H7. You don't have to remember this name, but just have a good look at this number, because if you see this in any question or number, you just know that, yeah, it is related with HUS. Goodpasture syndrome, it's vasculitic syndrome, IgG deposits on renal biopsy, anti-GBM antibodies. These things to be crammed, basically. Nephrotic syndrome, malignancies cause membranous glomerulonephritis. We already discussed this in the membranous glomerulonephritis, like CA lung, colorectal carcinoma present like this. Micturating cystography is the investigation choice of reflex nephropathy. So reflex, I told you, like urine is flowing back to the kidneys. Usually in the bladder, there is a mechanism that that urine doesn't go back to kidneys, but if this is damaged, it can go back and cause a reflex nephropathy. And the type of nephrotic syndrome you see in these patients is, fast comment, reflux nephropathy. What kind of nephrotic syndrome you see? No comments? Focal segmental glomerulosclerosis, we just read FSGS. Okay, so reflux nephropathy is FSGS, just revising the things. And in these patients, if you want to diagnose a patient of reflux, what you do, you insert the dye from the urethra, and you just take some x-rays. And if you see the dye going up to the kidneys, that means the mechanism in the bladder that was stopping urine to go back to kidneys is no more active, and it is damaging the kidneys. So that's how you go for cystograph. So SCG, testicular seminomas. Ultrasound is the screening test for adult polycystic kidney disease. We discussed antimuscarinic drugs useful in overactive bladders, because antimuscarinic drugs will not let the bladder contract that fast. They just let it relax. So that's the treatment for it. The chromosome we discussed, like ADPKD type 2 is due to 15% of cases. Yeah, AV fistulas, preferred method of access to hemodialysis. Other options can be central line, PICC line, and from some, I have seen people doing it with cannula, but that's not a right approach. So fistulas are the best preferred method. Renal transplant. In renal transplant, who is the most important? Doctor is the most important. Okay, just remember it like that. If you're going for a renal transplant, doctor should be most important. It's not doctor here, it's HLA type of like DR, but remember renal, doctor. Alport syndrome type 4 we discussed. Nephrogenic diabetes. So diabetes insipidus is when there excess water going in the urine. There is deficiency of vasopressin that is produced in brain. So if the hormone is deficient, that is central diabetes insipidus. But if the hormone is there, but the receptors that are present in kidney are not good enough and are not modified to accept the vasopressin produced in brain, that's nephrogenic diabetes insipidus. So these are two different types of DI. In brain, the serum sodium will be higher on the higher side, but in nephrogenic, the kidneys are not good enough to concentrate try to concentrate the urine and save the sodium. So sodium will be less in the body. It's getting out in the urine. So the more common form affects the receptor diabetics. The renal DI is more common. The less common form results from mutation in gene that encodes the equivalent two channels. And things to just, these are the points to remember. Contrast nephro we discussed. In ascites, the best drug is spironolactone. I know you must have seen giving patients Ditor, but the first line and the best drug is spironolactone. Ditor plus, and the plus is spironolactone. That is the main drug. Guidelines to recommend the use of diclofenac in the see if there is a pain in a renal pain, like colic pain, you can use different drugs. There are some controversies, but till date you should use like diclofenac injection for the pain, although it can affect the kidneys as it's an NSAID and the kidneys undergoing stress due to stone, but still. And the other drug you can use is like the Urimex, that's finasteride that dilates the ureter so that the stone can pass easily. And up to 7 mm stone can pass in the like spontaneously, but if it's of more than that, then you should consult a urologist for the operation. And up to 5 is very much easy to pass through urine. 5 to 7 is the borderline, but still, if it's bigger than 7, then urology consults. So urine output, minimum urine output required for a normal kidney is 0.5 to 1 ml per kg per hour. So if a person of 60 kg is admitted to you, make sure that he's producing at least 30 ml urine every hour. But if it is less than that for 6 hours, then AKI has developed. Okay, next. Uric acid, we know, radiolucent and can't be seen in X-ray, so we'll go for ultrasound or CT, NC-CT KB. Rhabdomyola, IV rapid, we discussed. Flash pulmonary edema was on ACE inhibitor. Okay, so if a patient is, I told you, if the patient was having urea and electrolyte worsen on ACE inhibitors, and the shortness of breath is there due to that, and it's due to renal artery stenosis, you should go for MR angiography in those patients after doing US Doppler. Rapidly progressive glomerulonephritis can be seen in good posture or ANCA positive vasculitis. CKD often leads to anemia due to reduced level of erythropoietin. Normal kidneys produce erythropoietin that let the bone marrow produce blood, HB, blood cells. And if the kidneys are damaged, like if GFR is less than 45, then they are really not effective for producing erythropoietin, so patient will have anemia. And if a patient develops gynecomastia with spironolactone, like the ascites patient, the substitute for spironolactone is eplerenone. That's a different diuretic with lesser side effects, but it's a bit expensive. We discussed 0.62 and we revised it as well. Sterile pyuria with WBC cast in the setting of rash fever should raise the suspicion of interstitial nephritis. We discussed on the first slide Okay, so WBC cast, we discussed interstitial nephritis is there. There is fever, rash, trial pyuria. ADPKD is associated with hepatomegaly due to hepatic cyst. See, if the patient is of polycystic kidney disease, the cyst can be in lungs, liver, spleen, anywhere. So the patient might have hepatomegaly as well. ATN or pre-renal uremia. Yep. See, if there is an AKI, acute kidney injury in patients, and how we will differentiate if it is pre-renal or renal. Pre-renal is like if there is no enough blood supply, the patient is dehydrated, then it's pre-renal, that there is not enough supply to the kidneys leading to deranged RFT. But if it is renal, that it means some drug might have caused some damage to the kidneys. That's renal. So the main function of kidney is to preserve sodium. So if it is pre-renal, then the urine the patient is passing will have less urine because kidneys are functioning well. So fraction excretion of sodium, we call it FENA, will be less than 1% in pre-renal AKI. But if the kidneys are damaged due to some toxin or drug, then the sodium will be excreted more because kidneys are not able to absorb the sodium. So FENA will be more than 2%. If you just talk about the urinary sodium, if it is less than 20, that means kidneys are doing okay. Just dehydration or blood loss is there leading to kidney injury. But if it is more than 20, that means kidneys are not able to preserve the sodium. So that's how you differentiate between pre-renal and renal AKI. And diffuse proliferation, most common and severe form of renal disease in SLE patient, we discussed. Diffuse proliferation cause post-streptococcal and SLE. I told you it's PSG and glomerulonephritis, the most commonly seen in SLE as well, that we call it diffuse proliferative. Yep, next. Okay. Fanconi syndrome is a syndrome in which there is an abnormality in proximal convoluted tubule. PCT is the main part where all the bicarbonate or the sugars and everything is amino acids are absorbed from the urine. But in Fanconi syndrome, this part is defected. That means all the amino acid sugars are, going down the nephron and not absorbed back. That leads to short stature and things like that. So it's Fanconi syndrome. We also call it RTA type 2. It's a type of RTA type 2. Okay. Gentamicin can cause AKI. In AKI, if there is hyperkalemia not responding to medical treatment, we go for dialysis. And you can also see a reel like which patients should go under dialysis. I have posted it on my Instagram. I showed in the first slide Dr_Gupta_MD. I won't discuss it here. You just see that reel. There is a mnemonic like AEIOU. It's simplified. Okay. Yeah, I just told you it's mnemonic AEIOU, anuria, electrolyte imbalance, and stuff like that. We are running out of time, so let's just you watch that reel on my page maybe, and if you still have some questions, you can ask me there. Okay. In ADPKD, the mitral valve can also be weak, leading to prolapse. The setting of, okay, so rhabdomyolysis, we discussed lactic acidosis, hyperkalemia, and ATN, acute tubular necrosis. Can you guys comment what kind of cast you will see in acute tubular necrosis, ATN?
Excuse me, doctor.
Please.
Excuse me, doctor. Doctor.
Yeah.
Excuse me. I just want the indication for dialysis, please.
It's AEIOU, electrolyte abnormality, anuria, fluid overload, toxins, uremic encephalopathy. So these are the indications. Okay.
Okay, doctor. So what's
Yes.
what's the abbreviation? AE
IOU, all the vowels.
IOU.
Yep. Let's move to the next point. You can ask later if you have some other doubts. Yep. And okay. So can you guys comment what kind of cast we see in ATN, acute tubular necrosis? It's just a revision of the points we just discussed initially. It's okay if you don't remember it. Yeah, good. Abanya is doing great, answering all the questions. Okay, good. So, amyloidosis findings we discussed. Spironolactone acts on collecting ducts as an diuretic. So, do you remember I told you in DCT, sodium is absorbed and potassium and H plus ions are excreted. So spironolactone work on that channel, leading to preserving potassium and not exchanging it for sodium. So it is a potassium sparing diuretic. Just remember it. It goes handy when you practice. So EGFR calculator, we have Cockcroft formula in which it depends on the race, gender, weight, creatinine, and these are the criteria. It changes the GFR in patients. Antiphospholipase A2 antibodies we discussed in membranous glomerulonephritis. Alport syndrome, we gave you good mnemonic for that. Okay, for BPH, we gave finasteride, but the effect can be seen even after 6 months sometimes. Okay. And staghorn calculi, we discussed it's due to the infection. And if you want to remember the content, it's ammonium, magnesium, phosphate, and triple phosphate. So if you guys speak Hindi, it's amma 3P. Whenever there is staghorn calculi pain, you call your amma due to pain. So AM is for ammonia, MA for magnesium phosphate, magnesium, and phosphate is 3P is for triple phosphate. Okay. And form in alkaline urine, told you. A common complication of plasma exchange is hypocalcemia. Yes, whenever there is plasma exchange, hypocalcemia can occur. And upper respiratory tract plus renal involvement, go for ANCA. So there are different causes. I told you 4. They are mentioning only one, glomerulopatasis with polyangiitis. Okay. Then minimal change. The treatment is prednisolone. We discussed. Sorry, NSAIDs and ACE inhibitors here which cause prerenal AKI. Due to NSAIDs and ACE inhibitor ARBs can always affect the kidneys. So this is clinical practice as well. Yeah, 86 we discussed. Please next. Okay. Rhabdomyolysis can cause parenchymal AKI and characterized by elevated plasma CK. Creatine kinase is from the muscles. This is the last slide, guys. Stay with us. I can see the 3 participants when we started with 50, now we have 47. This is the last slide. I hope you guys will get few questions from this. So whenever there is muscle damage, CK is released, creatine kinase. So it will be increased with renal damage, dipstick positive, but nothing on microscopy, no RBCs on. So rhabdomyolysis, you can see lactic acidosis due to dehydration. Consider FMD in young patients with AKI who develop AKI due to inhibition of an initiation of ACE inhibitors. Fibromuscular dysplasia is a cause of renal artery stenosis. NSAID should be stopped in AKI except aspirin. Aspirin is more important because that is cardioprotective. If a patient is of MI, we should give aspirin and not to hold it. Okay, RTA causes normal anion gap acidosis. Things to remember. And whenever you are giving 3.9% saline, normal saline to a patient, if you give excessive saline, you can see the patient will have hyperchlorinemia. The chloride values in the serum will be increased because the normal saline has lots of chlorine in it. Okay. Organ transplant patients could have the infection with CMV. You remember that? And the other thing you can remember is whenever there is organ transplant and there is immunosuppression, squamous cell carcinoma is common to get. So you have to make sure that patient is screening himself for squamous cell carcinoma. CKD, if we are diagnosing CKD stage 1 or 2, like GFR up to 60, then you have to look clinically along with the GFR. Okay. Renal cell carcinoma can metastasize to lung and remains an important differential in the setting of hypertension, hypercalcemia, and hematuria. So these are the points. And okay, guys, I think the session is over now. Yeah. So I hope you all love the class, and please try to give us some feedback, because if you can tell us how to improve the class, because it's my hobby to teach students, and the medicine is something I love from the core of my heart, and I'm gonna continue with medicine only. So, and if you think some topics are missed, maybe we'll cover them with the surgery or in the other sessions as well. And we can also host a different session in which you guys can ask us to teach the topics you think are important or are coming, although we try to cover everything. So that
Could you please,
don't
doctor, could you please send the recording?
see, even I don't have the I don't have the recording. This is Asma who is organizing. She is the main person in this session,
Yeah.
right?
Can you send for us feedback and
Yes,
recording,
Dr.
please?
Yes, Dr. Hawaida, we are going to provide the recording by tomorrow. So you all will get the recording of the session.
And also,
Yeah.
I mentioned for you, I need some sort of discussion with you.
Yes, Dr. Hawaida, after the session, I will give you a call and then we can discuss about everything.
Thank you very much. Thanks, Asma.
Okay. So
Excuse me.
Mhm.
I have a question. I'm Dr. Amir.
Mhm.
Actually, very nice session. I'm really impressed. That was my first ever time that I have got the nephrotic, all this brief discussion.
Thanks.
Actually, I just want to ask one question regarding the CK, because as you discussed that the muscle damage,
Mhm.
but we have seen most of the youngsters which they use the gym and they do the physical activities or somehow use the the proteins or the whey proteins. So is there any you may say the clear cut line or the clear cut demarcation by the differentiating either it is the disease or the problematic CK or somehow by using the gym or something normal physical activity?
See, this is like what I tell my patients as well, like, because sometimes in OPD we see young patients coming with blood in urine, uh, who are going for multiple sessions in gym and doing excessive exercise. Every time you go to gym and you are working out, there can be muscle damage, and everybody responds differently with different CK levels. So there is no differentiation like this is the dangerous level or this is not. But you should keep hydrated. So if any of your patient goes to gym and CK value is increased, tell them that they need to warm up before going to the gym and stay hydrated and get their renal function tested. But the mistake I think the people do, they take the protein powders, creatinine, and things like that to bulk up, and then they do the excessive workout, leading to dehydration and muscle damage, leading to myoglobinuria. So no, it's not so common, like it's not like everybody will get it, but once you are suspicious, you should be aware like these things can be damaging. Okay.
Thank you. Yes, and another so last question, which you have mentioned that like the NSAIDs are the painkillers, which we have heard most of the patients, like as a layman, that they do ask that which kind of painkiller or which kind of analgesics do damage our kidneys. So is there any classification in medicine?
There is NSAIDs, or there is NSAID itself is a classification which contains different drugs that can damage kidneys due to inhibition of prostaglandin synthesis in the kidneys. So the prostaglandins dilate the vessels, and if there is inhibition of that, they can't dilate it, and there is increased pressure and damage. So the best painkiller right now is, I would recommend, is paracetamol you can use. So that's the basic. And so guys, the thing is, right now I'm working and I have to go early tomorrow. So I think I'm done with the session, right, Asma?
Yes, Dr. Rajat, thank you so much for today's session.
Yeah.
I guess all queries have been answered. So if there is any other query, you can also send it to us. We're going to, guide you all.
Yeah. And you can also ask me on Instagram. I can reply whenever I get time, or otherwise in next session, or we'll arrange a session where I answer your doubts maybe. So I hope you like the session. See you all the best. Prepare well. Bye.
Thank you very much, doctor.